Hey guys, this is Dr. Joel with MedImmersion.com. I'm coming at you with another Flash Flood review series video where I cover the highest yield stuff for your board exams and clinical rotations in as little time as possible. This video is very concise and right to the point. It's awesome. If you've listened to a lot of these introductions and you're tired of seeing the same thing over and over, go over to MedImmersion.com, get an account, and in most cases, you'll skip right over these intros and a lot of the YouTube advertisements on my videos and everybody else's videos that I've linked to, and you'll just jump right into the meat of the lecture. Today, I'm going to talk about anemia. It's going to be super cool, so let's jump into it. After a quick intro, I'm going to talk about red blood cells, then young red blood cells, also called reticulocytes, then some calculations that we do to correct for the reticulocyte count, called the Reticulocyte Index, the Reticulocyte Production Index, and then I'll jump into kind of an overview about diagnosing anemia and the two major approaches, the Kinetic Approach and the Morphologic Approach. Okay, let's do it. All right, dudes and dudettes, anemia workup is pretty common in your clinical rotations, whether it's in the hospital or in the like the family medicine clinic. You're gonna need to know it. You're gonna see it several times, and so it's high yield. Also, if you don't really know the CBC or the complete blood count, go check out that video first because you need to understand the CBC in order to do an anemia workup. So what the heck is anemia? Well, strictly defined, it is a decrease in the total number of red blood cells or a reduction in the total red blood cell mass compared to what's normal by blood volume studies. However, a blood volume study is slow and expensive, so what you're going to see in practical use is you're going to get a CBC and you're going to look at the hemoglobin and the hematocrit. There's all kinds of things that cause anemia, and oftentimes when you see a person with anemia, they are sick in a lot of different ways, and so there's often multiple factors that contribute to their anemia. But that's not how I'm going to teach it here. I'm just going to teach it as if each cause is the only cause. Okay, that's just how you have to learn it. Commonly, blood loss and iron deficiency anemia are at the top of the list. You're going to see those quite a bit. Also, B12 and folate deficiencies or nutritional deficiencies, and then anemia of chronic disease and anemia of kidney disease are also pretty common. Next up, let's talk about a few things to set the foundation or the scaffolding that you can build on to understand anemia and how we work it up. And I'm going to do that by covering a couple of basics. If this is too basic for you, you can skip past it, that's no problem. So I want to kind of talk just a minute about red blood cells. Red blood cells live about 100 to 120 days in your system, okay? That means that you need to replace about 1/100th or 1/120th of your red blood cells every single day. The production of red blood cells is called erythropoiesis, and it occurs in the bone marrow from stimulation by a hormone called erythropoietin, which is made in the kidneys. And if you'll remember, I said one of the common causes of anemia is kidney disease. And this is why the hormone that stimulates the production of red blood cells is made in the kidneys. So if the kidneys aren't happy, they're not making that hormone. Also, healthy bone with all of the required substrates that it needs to make red blood cells can make up to 5 times more red blood cells than you need or that you lose from daily losses, okay? So that's quite a bit more. You have the ability to produce 500% more than you lose daily. But what would that look like? Well, I guess you would see a lot of immature blood cells floating around, right? If you started making 5 times more red blood cells, well, there'd be a lot of young, juvenile, or immature blood cells floating around. That makes sense, right? Yeah, it does. And those are called reticulocytes, or immature red blood cells. Under the microscope, you can tell the difference between a reticulocyte or an immature red blood cell because they are slightly larger than their more mature elder brothers or sisters. And also they have some intracellular structures or fragments of ribosomal RNA still visible within inside them. This is called polychromasia. Make sense so far? Okay. What about this? If the reticulocytes took about a day to mature, and we know that we lose about 1% of our red blood cells per day, what do you think the normal percentage of reticulocytes in your blood would be? You got it, about 1%. We should see about 1% reticulocytes for a given number of red blood cells, okay? So following that logic, what would you think if I told you that you had a normal hemoglobin and a normal hematocrit, but you had a very high reticulocyte count? What would that suggest mathematically? Well, it would suggest that the lifespan of your red blood cells was somehow shorter than 100 days. So if you had, 5% reticulocytes, that would suggest that you have to replace 5% of your red blood cells per day, meaning that you're losing 5% of your red blood cells per day to maintain your normal hemoglobin and hematocrit. Well, that works. That makes sense. And we use that principle when we're working up anemias. And I'm going to build off this, and I'll show you how it works, okay? Let's move on. So in the process of building you up, the first thing I need to do is explain that the reticulocyte is a great thing to know. The reticulocyte count is a great thing to know. But if you use it all by itself, it has some shortcomings when you're trying to figure out anemia. And there's two that we need to correct for. The first one here is that in anemia, by the definition, we have a low number of red blood cells, right? And the reticulocyte count is a percentage of those red blood cells. So that kind of gives us a falsely elevated reticulocyte count. We have to correct for that. The second thing we need to correct for is that when we are anemic, our bone marrow is stimulated, at least healthy bone marrow is stimulated, and it starts producing more reticulocytes and also starts releasing them into the circulation earlier and earlier in their maturation process. So they come out even more and more juvenile, essentially. And it takes more time for them floating around in circulation to become healthy, mature red blood cells. And to correct for that, we use a simple correction table. So let's look at the calculations for these two steps and what they're called in the next slide. First off, here at the top is the Reticulocyte Index, and that corrects for the falsely elevated percentage of the reticulocyte count just because there is less blood in the system. So let's work through an example here. Let's say the reticulocyte count is 1.0, which that's normal, right? In a couple slides ago, I told you 1% is normal. However, the hematocrit is 15. 15 is about a third of what it should be. So 15 over 45, which is a normal value for hematocrit, times the reticulocyte count of 1% equals like 1/3 of a percent. Well, that's definitely too low. Okay, so does that make sense? Let's change it up. The reticulocyte count is now 3%. Whoa, that's way too high. It shouldn't be 3%. Well, hold on a second. What's the hematocrit? Well, the hematocrit is 15. Normal's 45. So the reticulocyte index is 1.0. We've corrected for the change in the amount of blood in the system. Awesome. But did we correct completely? The answer is no. We still need to correct for the maturation correction factor, which is from this table here. So what do we do? Well, we say the hematocrit was 15%, So therefore, we go over and we use the 2.5. It takes 2.5 days for those reticulocytes that were released from the bone marrow to fully mature, which is 1.5 days longer than they should take to mature. So what do we get now? Well, we get 1.0 divided by 2.5. Thus, the answer is 0.4. The Reticulocyte Production Index, or the corrected reticulocyte count, is 0.4. What does that mean? What should it be? It should be greater than 2, or preferably 3. So in this case, even though we started with a reticulocyte count of 3, the bone marrow is just not putting out enough blood. So diagnostically, where does that steer us? Well, that kind of steers us towards a bone marrow problem, doesn't it? See where I'm going with this? See where I'm taking it? Pretty cool, right? Let's do another example, but this time let's show an example where the bone marrow is doing what it's supposed to do. And we are going to start with a reticulocyte count of 18. So 18 times the patient's hematocrit, which was 15, divided by 45, gives us 18 times 1/3, or 6. The reticulocyte index is 6. Then we put 6 divided by the maturation correction, which was 2.5. Therefore, the reticulocyte production index is 2.4. Perfect. The bone marrow is doing what it's supposed to do. Our patient is anemic, but we know that the bone marrow at least is working the way it's supposed to. Well, diagnostically, where does that steer us compared to the previous example? Well, that means that the problem is happening in circulation. Maybe we're losing blood. Maybe we're lysing blood cells. But it points us away from the bone marrow to other diagnoses. Right? Yeah, cool, huh? So now that you are practically a hematologist, let's move on and talk about the art of diagnosing anemia. And it really is just that. It is an art. It takes time and practice to get good at diagnosing anemia. In fact, it takes time and practice to get good at diagnosing anything. The skillful interpretation of lab values and the workup of diseases is a lifetime pursuit. Don't forget that. It takes practice. That's why we say the practice of medicine instead of the mastery of medicine. Okay? So, diagnosing anemia takes more than just lab skills. You also need a little bit of clinical prowess. If you see melena in your patient, your diagnosis should be focused on the GI system and GI losses instead of hereditary spherocytosis or sickle cell disease. Okay? So how do we approach the diagnosis? Well, there's two main thought processes, and I think both of them have value for you. The first one is the kinetic approach, and the second one is the morphologic approach. All right, the kinetic approach. And listen, guys, this is by no means going to be comprehensive. This is very basic, and it's going to allow you to build on it in your clinical rotations. I just want you to understand the thought process. So, the kinetic approach. This is kind of taking over. The kinetic approach is getting more and more popular, and it's being taught in major hospitals all around the country. It's kind of the way that medicine is going, and I like it. It's awesome. The diagnosis is a process of solving for the mechanism of the anemia. And we do that by looking at the RPI, or the Reticulocyte Production Index. And you'll remember from what I've previously said that if the RPI is low, then that suggests, and in the anemic patient, RPI is low, that suggests that maybe you've got an underproduction problem. Your bone marrow just isn't putting out enough red blood cells, and so you're anemic. And if we go that way, we end up in another flow chart that looks a lot like the morphologic approach. So I'm going to put a pin in it right there, and we're going to come back to that in a second. Let's flip over to the other side of the flow chart. Let's say you have a high reticulocyte production index, and your patient is still anemic. Well, that suggests that your bone marrow is producing enough red blood cells. It's trying to keep up, but you're losing them somewhere else, like you're lysing them, or you're just losing them. So let's start with hemolysis first. What would you do if you suspected hemolysis? What are some other labs that you could do? Well, you could get a peripheral blood smear, which could show you some schistocytes, and that would point you in a direction. You could confirm that you're getting hemolysis or hemolysis by getting a bilirubin, which is going to be a breakdown product of heme, a lactate dehydrogenase, which is an enzyme that's spilled from a lot of different cells, but when you're lysing a lot of red blood cells, that's going to be elevated. And haptoglobin. Now, haptoglobin is actually going to be low. Haptoglobin is a protein that floats around in your bloodstream. It captures or binds to free-floating hemoglobin as a protective measure. And it's a protective measure because free hemoglobin can be dangerous. It can cause oxidative stress to other cells, and also, if we're not careful, we could have renal losses of iron, and other organisms would take advantage of iron in the system, and they would be able to grow much easier. The direct Coombs test, you could do that looking for an autoimmune disease, okay, and other things as well, but this is a good framework. What about blood loss? Well, blood loss is going to be more of a clinical diagnosis. You see a patient with melena, you're going to go straight for GI causes. You see a patient with massive hematuria, you're going to go for GU causes. What else? There's all kinds of things. You could have a rigid abdomen after a surgery. You could have a lot of things that would suggest that this patient is just plain bleeding and they're losing blood that way. All right? Well, let's switch around and go back over and look at the morphologic approach. The morphologic approach is a little bit more old school, however, still very useful. Number one, because it is part of the flow for the kinetic approach. You're going to need to go down this route anyway if you have a low reticulocyte production index. Also, this is maybe a little bit easier to do in a small clinic where you might not have a machine to count reticulocytes, but you can get a CBC and a mean corpuscular volume, or an MCV. So there is still value here. The diagnosis in the morphologic approach is made by observation of cell changes versus the kinetic approach, again, which was looking at the mechanism. So the cell changes could be from a variety of different mechanisms, but the same cellular changes would be seen. Let's start with macrocytosis. If we see large MCV, or greater than 100 femtoliters, then we think, what are the many things that could make my red blood cells too large or give me a macrocytosis? Common things being common, you might think about folate deficiency, B12 deficiency, liver disease, alcoholism, or anything else that causes a reticulocytosis, because as I talked about before, reticulocytes are just bigger than mature red blood cells. So the machine will count them as being red blood cells, but it will just say that they're bigger, which will increase the mean and thus give you an elevated MCV. So the labs that you would follow to diagnose those should be pretty straightforward, right? Folate, B12, we can check those. We can also send the blood off or do it ourselves and count the reticulocytes. We could get a liver panel. We could find out the patient's history. Are they abusing alcohol? And we could even ask them what kind of drugs they're on, because some of the drugs might do that as well. Shifting over to the normocytic, let's say that we've got an anemic patient and the MCV is in the normal range. Well, shucks, that could be a whole lot of different things. Common things being common, we probably have some kind of blood loss or hemolysis going on in the system. So we're going to do a lot of the same labs that I talked about already. You're going to want an LDH, a bilirubin, and a haptoglobin. You should ask for those right away. You should also get a renal function panel, because if you're not producing enough erythropoietin, you aren't going to have stimulated bone marrow to make red blood cells. And again, you're probably going to want to know the reticulocyte count. What about microcytosis now? Well, the first thing that you're going to want to do if you see small red blood cells or red blood cells that are smaller than 80 femtoliters, you're going to want to jump on your iron studies right away. Reason number one for doing that is that iron deficiency anemia is a major cause of anemia in general, so you might as well start there anyway. And number two, it's going to narrow down the field a little bit. So let's say your iron studies look like this. You've got a low iron, you've got a high total iron binding capacity or transferrin iron binding capacity, and a low ferritin. What does that mean? Well, that just means you don't have enough iron. Your serum iron is very low, the iron binding capacity is very high, and the ferritin, which is kind of like your reserve iron, is also low. So you just don't have any iron. This is iron deficiency anemia. Here's some iron supplements and a multivitamin. Have a nice day. What if you've got normal iron studies, but your patient is still anemic and the cells are microcytic? Well, then you're probably going to want to do reticulocytes and maybe a hemoglobin electrophoresis looking for thalassemias. What about low serum iron, low TIBC, meaning there's not a lot of room for extra iron in the blood, and a high ferritin, meaning that there is a lot of iron left in the reserve system? Well, you could be looking at a case of anemia of chronic disease, which can be from a whole host of problems. Maybe your kidneys aren't happy, or your bone marrow is being interfered with in the production of red blood cells by a lot of cytokines or inflammation, things like that. Lastly, let's say you've got a high serum iron, normal TIBC, a high iron reserve, or a high ferritin. Maybe you should do a smear in this case and look at the red blood cells and see if you see any basophilic stippling or ring sideroblasts. You could also think about doing another liver study. This could be sideroblastic anemia or liver disease or even heavy metal poisoning. Okay? So again, guys, you've gotten through this. I hope you have a better understanding of how to digest the information coming at you about an anemic patient. And maybe this gives you a better framework or foundational understanding so that you can really go in there and knock it out of the park. All right? Dudes and dudettes of YouTube, thanks for watching this video. I love making these things for you, and I hope that you're a little bit more comfortable on anemia now. So show your support for MedImmersion if you like this video. Leave me a comment, subscribe to the channel, give me a like. In the upper right hand corner you can make a donation if you'd like. Any little bit helps us keep the lights turned on, so that would be awesome. And as always, hey, good luck in school. You can do this.